First of all, in organizing these CPD sessions. CPD means continuous professional development. It means that by the time you leave these presentations, you will have value added. Not all the things are got from school, but some are got after you have qualified as a professional. As I've said, Busoga Health Forum remains the premium and #1 CPD provider. As per introductions, I am Othiniel Musana. I'm a gynecologist and the immediate past president for AOGU. That's the body linking all gynecologists in the country. In the east, we have 3 branches, which is Busoga, AOGU Busoga, AOGU Teso, and AOGU Karamoja. And all those areas, Busoga Health Forum is the premium and #1 CPD source. I also travel the country, and even in the central, when you ask the doctors, the clinical officers, and the others, Busoga Health Forum remains the premium CPD provider. So thank you for the good work you're doing. And I hope that members continue to subscribe to the BHF to ensure that this work continues. And many of us have benefited. Now, back to the topic of the day. We are discussing this. We are honored to have this evening the Executive Director of the Save the Mothers East Africa, STMEA, that's the abbreviation. This program has been here for several years and is empowering many of the gynecologists, nurses, social scientists in public health leadership for maternal health especially. And we know that many of their the people they have skilled have gone back and created an impact, not only in reproductive health arena, but also in other areas where they are employed. So this evening, we are honored to have the Executive Director, Dr. Nsubuga Mushin, an obstetrician gynecologist, who will take us through the current challenges and solutions in maternal health in Uganda. I was privileged to attend a meeting recently, and I think that maternal health should also join the so-called parish development model, and we should make an impact there. And I think Busoga, as Dr. Tatuma says, is an area where maternal health has issues. So Dr. Nsubuga Mushin, we will welcome you to share what you have with us today. And I know people will be better and have value when they leave this session. Dr. Nsubuga.
Thank you very much, Dr. Musana. I'll start by introducing myself. I'm called Dr. Nsubuga Mushin. Just like Dr. Musana has introduced me, I'm a gynecologist, and I've worked in the rural areas of Uganda, serving the rural communities for quite some years. And currently, I'm the Executive Director of Save the Mothers. And I would like to spend just a minute to talk about Save the Mothers. Save the Mothers is a non-government organization based at Uganda Christian University. That's where our offices of the East African branch are. We have branches in the USA and in Canada. What do we do? At Save the Mothers, we stand for no mother or baby should die or be harmed due to childbirth-related complications. Because a child can be born, a mother can deliver and stay alive, but go home with complications, sometimes that are lifelong. So we are saying this should not happen. And how do we do this at Save the Mothers at Uganda Christian University? We do this through majorly two programs. The first program is by equipping multidisciplinary professionals with skills in safe motherhood that enable them to go in their community and address the safe motherhood challenges in their communities. This is because we believe that a mother dying is not just a business of the health worker. It's not just a business of the midwife. It's not just a business of the obstetrician. Everyone is concerned when a mother dies. And many of these solutions are down there in our communities. So this is why we take this business down there to the lawyer in the community, to the journalist in the community. We bring it to the social worker in the community, to the LC5 chairperson in the community, to all the local leaders. It's our responsibility, to the father, to the mother. So we do that through that program, Masters of Public Health Leadership. The second program we have at Save the Mothers is the Mother Baby Friendly Hospital Initiative. Now, what does this program do? This program ensures that a mother delivers and feels respected, dignified, but also goes home safe with her baby. This is what that program is all about. And today we shall be talking about the 10 points of the Mother Baby Friendly Hospital. What should that hospital look like? Yes. And currently at Uganda Christian University, the intake is on for the Masters of Public Health Leadership. You can apply now, as we shall share later on. And enroll in September. Yes. So for today, we want to talk about the current challenges and solutions in maternal health in Uganda. Just like I've said, a mother dying is a business of everyone. Mothers who die in our communities, many of them are our neighbors, others are our sisters, others we work with them, and many are our daughters. So they are very close to our hearts. And many of us are mothers. I think that's why we are here today. So I would love a snapshot of the maternal health in Uganda. We might not explore everything, but we're just going to take a snapshot, looking just at a few areas that we shall be focusing on today. And we shall discuss how to address those challenges. Then we shall also talk about the Mother Baby Friendly Hospital Initiative and what it means. What is it? So from the UDHS of 2022, we clearly see that antenatal attendance by a skilled provider in the year 2022 was at 95%. But before you get to 2022, you realize that Uganda was doing very well from the year 2000. You know, we are improving from 90% to 93 to 95, 97. Then came 2022. Some mothers decided not to come to attend antenatal care by a skilled birth attendant. We dropped to 95. So that's a challenge. We need to ask ourselves, these mothers who used to come, what happened to them? 97, now we are dropping to 95. It may look like a small drop, but it is significant when it comes to human life. Because if mothers don't come for antenatal, then we shall not be able to identify the risky mothers. That means we shall not be able to have timely interventions. When you look at births that occurred in a health facility, I think as Uganda, we've been doing very well. From the year 2002 to the year 2022, we've been progressively improving, and currently we stand at 91%. But this should pose a question to us. If 95% of mothers are coming to attend antenatal in our health facilities, and we are having 91% coming to deliver with us, what does that mean? This basically means the mother came to the health facility at one point to attend antenatal and made up her choice. Probably there might be a few of them who didn't do it by choice, but some of them made a choice that they will not come to deliver with us in our health facilities. That's why we see a difference from 95 to 91. So I think that's also a concern. That's a challenge that we need to look at and understand why these mothers don't come back to us again after attempting to come for antenatal. They decide we shall not deliver there probably. Then all the mothers we've seen who came to the health facility were attended to by a skilled birth attendant, because we had 91% being attended to by a skilled birth attendant as per that data. I would like also to interest you to look at this graph, but specifically at the 29% of mothers who don't decide not to attend postnatal care. So these mothers, many of them have delivered with us, but after delivering, they are saying, I think there's no need to go back for postnatal care. Or they find challenges that make them not to return to us in the health facility. So for me, I want to focus on these two graphs for now. When you look at the first one, 95% of people are coming to attend antenatal with us. We are seeing 91% delivering with us. What is happening to the 4%? Those ones who deliver with us, 29% don't return for antenatal, for postnatal care. So after having contact with us at the health facilities, they are not returning for postnatal care. We should be asking ourselves why. The other important statistic I would like us to focus on is the maternal mortality ratio. As Uganda, we've done very well, because our target for 2025 for Ministry of Health was supposed to be 211. And currently we are standing at 189 deaths per 100,000 live births. I think that's tremendous, and we need to clap for ourselves as Uganda. We've done very well. But while we clap for ourselves, we need to understand that we still have a goal to achieve of less than 70 maternal deaths per 100,000 live births. That means we still have to keep our guards on, continue with what we've done very well. But if we are to achieve this, we need to focus and go back and understand, how do we ensure that the 29% mothers who deliver with us at the health facilities return for postnatal care? Because complications still happen after delivery. For example, secondary PPH, even preeclampsia continues, and eclampsia in that phase. We still need to go back and understand, why is it that some mothers who come to attend antenatal care finally again don't deliver with us? So those are important questions to ask ourselves. And I believe if we focus there, we shall be able to achieve the less than 70 maternal deaths per 100,000 live births. A study by Bantebia in Hoima, Western Uganda, found that the use of primary health care units, just like the health facilities where many of us work, and the referral hospitals, was considered only as a last resort in this research by mothers. This meant that when mothers thought about where to deliver from, some of these health facilities were considered as a last resort. That means they had other places they thought about first. This same study found that lack of skilled staff at the primary health care level, complaints about abuse in the health facility, neglect of our clients when they come to hospitals, poor treatment in hospitals, poorly understood reasons for the procedures, meaning that we are not explaining to our clients why we are doing certain procedures, and health workers viewed that women were ignorant. So those factors explain the unwillingness of women to deliver in health facilities. Also, a study conducted by GYNAE-ONCOLOGIST in 2020 reported that the factors that were associated with women's choices of delivery sites were availability of the health center. In Uganda, we are saying at least in 5 kilometers, there should be a health facility where a mother should go. The other factor was level of education attained by this mother, so the level of education by the mother. But more importantly, the affordability of friendly services. So these friendly services were expensive, so a mother would have to choose otherwise. And also the behavior of the health workers at the health facility. So our behaviors as health workers significantly influenced the mother's choices. So the result revealed that having unpaid health fees, that means free health services, and hospitality of health workers were predictors for choosing antenatal health care facilities. So when you look at those two studies, what the studies are trying to say is simple. Are the health facilities friendly? The friendliness in the health facilities makes mothers come to deliver in the health facility. And there are several factors that make a health facility friendly. So Save the Mothers at Uganda Christian University, together with Ministry of Health, at one point came up with this model that we call the 10 steps of a mother-baby-friendly hospital. Why a mother-baby-friendly hospital? If the hospital is friendly to the mother, then most likely it's going to be friendly to the baby. If the hospital is unfriendly to the mother, then it's going to be unfriendly to the baby. When mothers come to our health facilities, what they are looking for, they are majorly looking for 3 things. Number 1, safety. When I walk into this health facility, will I be able to go back home alive? That's the first question they ask themselves. Will my baby be alive? Safety. The next question is the experience they get there. Do they feel respected when they enter this health facility? Or at the entrance of the health facility, someone's already barking at this mother? Do they feel dignified? Dignity means many things like you are going to say, but for example, when I come to this health facility, am I delivering on the floor of the hospital? The windows in our labor suits broken, mosquitoes are coming in. Is there water in this labor suit? Is there a toilet facility which is clean in this health facility? That shows dignity. So basically, the 10 steps of the mother-baby-friendly hospital, that's what they want to achieve. And quickly, I'll list them. Number 1, respectful and dignified care. A friendly hospital to the mother and baby, what we call a mother-baby-friendly hospital, to basically give this mother a sense of dignity and respect. It should have emergency obstetric care for the mother and also the newborn. That when there's a new, there should be effective communication to the community. We shall be expounding to some of these things. There should be appropriate documentation during the care of the patients. There should be protocols established, but also enforced, acted on, not just hanging on the wall. These facilities should be able to nurture friendly and motivated workers, because it's only the friendly and motivated workers that are going to deliver finally the safe, dignified care to the mother and baby. It should be family-centered with feedback to the family, because the mother comes from a family. This baby is being born into a family. You don't expect to take care of only the mother and the baby, and we forget that there is a father and the extended family. There should be a functional referral system in this health facility. And this health facility should be able to have baby-friendly hospital standards, as we are going to see. And we encourage that this health facility should have ongoing certification to ensure that over time we keep on checking, are we adhering to the standards of the mother-baby-friendly hospital initiative? So this program has been enrolled in 15 hospitals in Uganda, including 1 hospital in Tanzania. It has seen significant advances over the years it has existed. For example, 12 free lines that enable good communication, timely communication whenever there is a referral, but also an emergency within the health facility. There has been provision of water supply to hospitals that have not been able to have safe and clean water for our mothers who come to deliver. This program has been able to provide equipment that has been instrumental in the management of emergencies during delivery, but also in resuscitation of the newborn. We've been able to set up several HDUs in hospitals. HDUs are high dependence units where critically ill mothers are admitted, monitored, and taken care of in order to improve their outcomes. And this greatly reduces the numbers when it comes to maternal deaths. It averts deaths. A lot of on-site mentoring of workers in emergency obstetric care, but also self-leadership and financial literacy, as we shall see down there. So the first step of a mother-baby-friendly hospital initiative is respectful and dignified maternity care. What do we mean when we talk about respectful, dignified maternity care? Respect and compassion should be the foundation of maternity care. A mother should feel respected when she comes to the hospital. She should feel loved. Do we call them by their names when they arrive? Or we just say, Mama, Mama, walampe chitanda, but they have told us their names. Do we welcome them? Mama, tusanyisa okulaba mu ddwaliro, tukuyambye tutya buzibu ki munnaye. They should feel loved. You know, when I come to visit you at your home and I don't get this kind of welcome, you're welcome. You know, I don't feel at home. So the first thing is that they should feel welcome. We should be able to communicate with the women in a culturally sensitive manner. Many of us know the nature of our wards where we work. You may find one bed is very close to another. You may find that the mother is here with her mother-in-law taking care of her. And we are asking about how many times did you have sex? You know, very sensitive questions. So we should communicate with the woman in a culturally sensitive manner, okay? These mothers must have a right to informed consent, but also refusal or decline. For example, when a mother comes, many times we are just saying, climb the bed, remove the underwear, and before they know our hands are in there for the vaginal examination, and they are jumping and kicking everyone, then we slap them saying, why are you kicking me? We should be able to tell them, you know, I'm going to perform a vaginal examination. It might be uncomfortable. However, if you relax, it may not be that uncomfortable. And I'm going to request you to remove your underwear. And this is what I'm going to do. And most likely she will say yes. But also she has the right to say no. But most importantly, as health workers, we should make sure that she's saying no. But after getting the information, why this important examination is required and what's the benefit. So it's very important. No physical, verbal, emotional abuse of a woman, or even to their newborn, not even to their family members, is ever allowed a mother baby initiative. We can't tell them push while slapping. That's why probably many of them don't turn up for postnatal care because of that emotion they have, because of that bad memory they have. So we need to change in these kinds of areas. We need to establish a supportive environment by listening to our mothers. Many times we ask them the questions. Before they answer, we're already asking another one. Probably they want to explain how the other pregnancy was. So it's very important to listen to these mothers. We need to communicate in a language they understand. This mother doesn't know induction. Let's put it in very simple language. Very simple. Otherwise, when you talk to them in a language they don't understand, many of them you ask them, they can't tell why they were even operated. Why? Because you explain to them in terms they don't understand. You need to avoid the routine use of potentially harmful procedures in normal labor, even in postpartum periods and neonatal periods. And many of these procedures probably are there to save the life of the mother. But at that point in normal labor, they are unnecessary. For example, every mother who comes in, we put a catheter. Every mother who comes in, we want to put an IV line. But they are drinking. They're able to drink. They are not vomiting. They are happily walking around, but they have a drip on them. I think at that point, it's unnecessary. Baby is stable, mother is stable. Let them drink. Let them walk around. Let's not have an episiotomy for everyone. These are some of the things that just our mothers are aware that put them off. The other very important thing is that labor is a painful process. We should be able to offer measures to manage this labor. Many of them are going to be non-pharmacological and very simple ones. For example, how do you relax? How do you massage the back? Let's give them these options. And many times we may tell them, massage the back, simule visa. And we don't educate them how to do it. And you find a caretaker giving, really massaging hardly to an extent that someone's skin gets bruised. Then she goes back with a very bad experience. Yet it was intended actually to help her take away the pain. In places where pharmacological pain relief options are available, we should be able to explain their benefits and risks. But most importantly, we should support the mothers to make their informed choices in a confident manner. Now, a respectful and dignified maternity should be able to support a woman who is laboring to walk around freely. Let's not tie them on drips when they are unnecessary. Let's not keep them on the beds glued there. Let them walk around freely. We should be able to tell them that, you know what, we've just examined you right now. Your baby's heart is good. You're also in good condition. The next exam will be in 30 minutes. We shall be listening to your baby's heart. And that 30 minutes will be at such a time. You even tell the caretaker, kindly remind the mother that at this time we shall be examining her. And then she moves around. We should allow them to assume positions of their choices during labor. Provide them with those tools they need. Privacy during labor and delivery is key. We shouldn't make one mother pushing here. There are no curtain, there is no form of a wall, and another mother next bed is also pushing. The caretaker of the other one is looking at this other one. There is no privacy at all. Such a mother will never have a good experience. At Save the Mothers, we've had simple interventions as simple as putting curtains in labor wards. And this has improved the labor ward attendances and deliveries in the health facilities where this model operates. Provision of water, and this water is in two parts. You know, I've had an opportunity to visit a traditional birth attendant, and when you go to a traditional birth attendant's place, you find a big kettle boiling water on firewood. So every time the laboring mother needs a cup of tea, they're able to drink. She needs a bath, she can get warm water for the bath. Come to our health facilities. Even drinking water is bought. Anyone can be able to donate a kettle to a health facility to boil water. That's why we said solving some of these things, it doesn't only require health workers. The whole community should be engaged. Toilet facilities. A good maternity facility, labor ward, should have a toilet in labor. A laboring mother should not walk a distance to go out to access toilet facilities, and they should be clean. Emergency neonatal and obstetric care. Now, we need to ensure that staff are trained in the timely recognizing of potentially dangerous conditions and complications, as well as providing effective treatment. Why? You see, having a doctor and having a midwife doesn't mean that that doctor or that midwife is a trained birth attendant. There are going to be situations where me as an obstetrician, in that given circumstance, I'm not a trained birth attendant. For example, if my skills in conducting a breech delivery are not up to date, in that circumstance, I'm not a trained what? birth attendant. So what does it mean? We need to continue doing mentorship, training, continuous medical education to equip ourselves, to refresh our skills, such that we are on top of our game, such that at any one point, we are traditional, we are trained what? Birth attendants. So these are very important. We need to have drugs, devices, equipment to treat mothers and their newborns when complications occur. So in our mother-baby friendly spaces, hospitals, these things must be there. We need to ensure birth preparedness and emergency readiness during pregnancy. And as a mother-baby friendly hospital, this can be done through community engagement. We don't have to wait for mothers only to come to hospital. We should tell them that they even know this before they conceive. And when they conceive and they come for antenatal, we should be able to give them this information. How do you get ready? How do you prepare for an emergency? What are the different emergencies? What are the different danger signs? Mothers come to our facilities, and during antenatal, you find that a mother has only spent 3 minutes in the clinic and she's gone. Their friends, effective communication to the community. Now, what is very important is that we need to understand that the mothers who come to us, first of all, they live in the community. Our health facilities are in the community. When a mother dies, it's the business of the community. So it's very important that we empower our communities through the dialogues we have with them by giving them information. This number of mothers died last month. This mother died because of bleeding. She delayed to come to hospital. Why? Because she had no transport money. And then we educate them at that point. Why is it important to prepare to always have transport when a mother is pregnant? So these dialogues are important. And you realize that because of these dialogues, the communities own up. They own up and actually come on board to help and make our facilities mother-baby friendly. So let's engage the communities if we are to make our health facilities mother-baby friendly. Appropriate documentation. Now let's ensure adequate documentation of key data elements. Why is this important? It's for accountability to start with. Number one, when I sign in that I've come to work, I sit and take a cup of tea. But the files of the patient don't show that I've given medicine, I've touched a patient. And then I'm logging out at the end of the day. So let's be sure that we are documenting. We give the drug, we document. We examine. Anything not documented is also not done. That's what it means. So let's ensure that we are always documenting for accountability, but also for quality improvement. How? This data we collect after being neatly documented, we use it to generate and drive change in our health units. If we discover that last month our patients were getting complications and some of them died because of such a reason, then we're able to address it. Maybe we had a long waiting time. Maybe our ambulance delayed somewhere because it had mechanical conditions. We are able to address it and work on it. Probably we didn't have blood. Then we start discussing how does our health facility mobilize blood? Protocol establishment and reinforcement. When you read the MPDSR report, the most recent one, there is a very nice graph there that shows that 70% of the maternal deaths that were audited, they had inappropriate intervention. Inappropriate means what? What was supposed to be done is not what was done. Either due to wrong treatment, wrong doses, you know, inappropriate what? Intervention. So how are we to hang? Let them not just hang in our labor suit. Let's have drills to practice these things. Let these things be on our fingertips. Let me walk in a labor suit and I ask someone management of PPH and they take me through without even looking at the protocol. Let someone be able to tell me about administration of magnesium sulfate, you know, at their fingertips, but also in case they forget, there's a protocol to remind them. Now, the other very important thing is we need to nurture friendly and motivated health professionals. I like the senior health professional lady in this picture. She's walking confidently, proudly. But let me ask a question. How many midwives come to work when their children have been chased for school fees and they are at work, but their children are home and they are not at school? How many doctors come when they are having in their inboxes WhatsApps from their landlords saying, where's the month rent for the last 3 months? How many doctors are there and they can't afford even a meal? I've seen doctors who are broke that they can't even afford a meal. So if we have such health workers, then it's going to be very difficult to have a mother-baby-friendly hospital initiative. So a woman's confidence and ability to have a healthy pregnancy, birth, breastfeed, these are influenced by every caretaker they encounter. So imagine a pregnant mother who encounters a doctor or a midwife who had no breakfast and lunch. What kind of encounter are they going to have? Definitely, it's going to be a very bad experience for that kind of mother. The healthcare system should be able to take care of the needs of the provider. Number one, by providing adequate supplies, because the healthcare worker who has no adequate supplies cannot work well. Equipment, staffing numbers. You find one midwife is delivering 10 mothers. That's a lot of work. That means she's not going to be able to document. She's not going to be able to explain in a culturally sensitive manner to the patients. She will not listen to the patients. Our health workers should be able to work without abuse by their supervisors. Very importantly, providing self-leadership and financial literacy trainings. This we do at Save the Mothers. Why is it important? A health worker should be able to know, when I get my salary, what else can I use it for to be able to improve my income, such that I'm not collecting money from patients in a government health facility. If I have other investments, I should not be able to do this. If I have other sources of income, I'll happily sit down in a health facility. Self-leadership also means, what time am I supposed to be on duty? I should be able to manage my time very well. I should be able to know that when I report on duty, this is how I organize to do my work neatly. So these are all important aspects that they don't teach us in medical schools or nursing schools and midwifery schools. But through the Mother Baby Friendly Hospital Initiative, we are able to enhance all these kinds of skills. Now, a Mother Baby Friendly Hospital Initiative, the hospital should be family-centered. Many times you go to a hospital and the husband doesn't know even the mother has delivered yet. The husband is outside of the labor suit, doesn't know what is happening. It's very important that, number one, we keep giving them feedback, involve the whole family in decision making, but ultimately, the mother is the main decision maker. If I'm in a small health facility in Namutumba, I should be able to have contacts of a gynecologist somewhere in Jinja Hospital, in Mulago, that I can, is bleeding, I've done this, I've done. Should have an effective communication system. A midwife should not be on duty and she's struggling to find airtime to call the doctor. We should have with enough airtime. There should be timely and safe transport of mothers and their infants to the referral facility, ambulance system. And we should be able to adhere to the baby-friendly hospital initiative by ensuring that our babies are breastfeeding. Breast milk is the best food for babies. In some health facilities, the baby is born and we're immediately buying cow's milk. We are buying formula milk. Commitment to ongoing certification. All the 9 steps we've talked about, it's always work in progress. So there should be some form of evaluation to understand where have we reached, where else do we need to go, where do we need to improve. So at Save the Mothers, through the Mother Baby Friendly Hospital Initiative, we conduct this and we certify the health facilities operating under this model. And we always work towards continuous improvement. Thank you so much. But as I conclude, I want to say that to achieve all those 10 steps, it takes a multidisciplinary kind of approach. Anyone in the community should be accountable for whatever we've talked about. We've talked about community engagement. There's no way community will engage if we don't empower them. So at Save the Mothers, we have this wonderful program called the Masters of Public Health Leadership. Now, this Masters of Public Health Leadership course is a 2-year course. It's an online course. You do your exams online, but that's not the most important thing. The most important thing is that this kind of course empowers a medical worker, empowers a lawyer, empowers a preacher, the clergy, that when I stand up on my pulpit on Sunday, I can talk about the causes of why mothers are dying. The 3 delays. There is no science about the 3 delays. About delaying to make decisions, is there science? Even a preacher can talk about this on Sunday. In Parliament, we are talking about maternal mortality ratios. Probably there might be one person in Parliament who has not heard about maternal mortality ratios in their life. They don't understand this, but they are making decisions. Someone at the local government, you're the one appropriating funds. You need these safe motherhood skills, information, to be able to save a mother. This is why I implore all of you to come and join the Masters of Public Health Leadership at Uganda Christian University. We are currently enrolling, and we shall be sharing with you on how to apply. Thank you so much. I think at this juncture, I want to hand over to Dr. Musana. Thank you for listening to me.
Not only for spelling out what Save the Mothers does, but also importantly introducing something that is being pushed, the mother-baby friendly initiatives in hospitals. There is a common saying which says, treat your customers like guests and treat your employees like people. So mothers should feel welcome in our facilities, but at the same time, we should balance it out with making sure our employees, the nurses, the midwives, people in the lab, are also managed like human beings so that they can share that love from small things like meals and other things. We will welcome questions at this juncture. If you have a question, please, you can raise your hand. Or you can write it in the comments. But what I can see in the comments is that thank you very much, Dr. Nsubuga, for this presentation. Such a masterpiece. As someone, I think this is Robert Njawuzi, says that thank you, Doctor, for the presentation. I can see where, as an individual, I need to improve. Then, of course, another John Paul Andama says, interesting, but some of them are difficult to achieve in very settings with staff shortages. For example, midwife attending to 80 mothers. Then, of course, Gladys says, thanks for reminding us about important procedures where we do all our preparations for other mothers. So please, Katamba, you can unmute and then state your question or your comment.
Thank you very much, Dr. Mushin. Am I audible?
Yes, you are.
Okay, it is not a question, it's just an addition. And I really like the way Dr. Mushin brought it up. Dr. Nsubuga, that was well illustrated. Now, one of the things that we've identified, my name is Alan Katamba Samakula. I work with USAID UHA. So MNH is my space, and that's why I really try to be in this, because I like listening to things that are there to save mothers and children. I just wanted to add that one of the things that we've also tried to identify is the fact that the mothers are coming to us in ANC1, but they are not finishing ANC4. The dropout rate is so high, and that is related to how the mothers are being treated by the health workers, like Dr. Nsubuga has said. Now that is pushing the mothers to deliver in the TBAs, it's pushing the mothers to deliver in unqualified places, the mothers to deliver in the community where they either lose their lives or they lose the lives of the children. That's why it's very critical that the customer care starts all the way from antenatal, from that first day they come, such that we can make sure that we retain them in the ANC cascade, but at the same time, ensure that they can come back for delivery. And that means that if we can retain them, then we can be able to do an adequate birth preparedness for us to make sure that everything is set for them to deliver timely, but also to deliver in a prepared place. And that's why right now, one of the things that we are trying to scale up or to promote is respectful maternity care in all settings. Can the midwives and the nurses and the health workers learn that when the mothers are respected when they come, then they would be able to come back today and tomorrow and the other day. And the other thing that I think I also wanted to mention is the issue of the high-risk clinics. We also realize that some of these mothers that do come to us and get, issues like PET, issues like PPH, they still get the same issues the next time they come to us. So one of the things that we are encouraging midwives, encouraging health workers is that, can you give an extra eye to these mothers through high-risk clinics, such that we can be able to prepare for any adversity in the event that some of these things occur. And we've seen more mothers being saved because of the high-risk clinics, but we've also seen more mothers being saved because of respectful maternity care, and the children are equally being saved. So I want to thank you, Dr. Mushin, for the good work that you're doing. And I want to encourage everyone here to see that we can save more mothers and more children. Thank you so much.
I'd like to thank you so much for that submission. I just want to say that for the high-risk clinics, those are very important components.
Matthias. Thank you. Unmute and then speak. I am wondering what's is with me or it is somewhere. Yes. Otherwise, thank you very much for the submission, and I'm happy that the presentation was reflecting two formats. First of all, evidence from the studies. Have some studies that have already taken place, and we are seeing facts coming from some of these studies. This is very good. The other one is that some facts are coming from the management point of view, as managers, as people who are responsible. How should we do things differently in order to change the status quo? And that's where I think my biggest issue of concern would be that one, we have a number of interventions that are running that are geared towards improving maternal and neonatal indicators. But many of them, a few of them are addressing the concepts of governance, concepts of management, yet they are very critical in terms of decision making and how we appropriate our resources. Many challenges that we have in our health systems are not because we do not have resources, but because we are not positioning our decisions rightly. And I want to pray that the university should as well tailor up short-term programs that are really focused, and we see how this should be tailored to address the real small issues at the lower levels. And that's where we have the biggest problems. Many of these mothers that are dying are not dying in the hospitals, big hospitals up there, but many of them are dying either at households before even reaching the health facility, or they are dying at the very low level health facilities. A few of them who die when they're in the hands of the general hospitals and upwards are attributable to still decisions that have not been taken appropriately well at the lower health facility levels. So when we concentrate down there, one of the issues that will come up will be that we shall decongest the upper referral facilities and minimize the risk factors at the household level. And I want also to pray that as we design some of these community health structure, many of these answers are actually around the households. And if the community health structures are well empowered, chances are that we are going to minimize the challenges that we are facing. But I want also to pray that if possible, in our designs, now things are coming up every now and then, attributable to our attitudes as healthcare providers, attributable to the way we appreciate the value we put onto our customers. And we really need to tailor a program that should address health service delivery as a business. And such that we now see business models that are touching the quality of care, that are directly linked to our indicators, and this should be directly fused into the funding mechanism. The financing mechanism should have an attribute on the business model, such that healthcare providers should move away from this laxity. And I would also wish that we need to go on and ensure that healthcare providers are contracted, and this contract should be renewed upon delivery of service and the results. Okay. Such that we begin seeing people who are moved to really changing the environment where we are working. Thank you very much.
Okay, thank you, Mangen. As Patrick Ochen unmutes, a comment from Mulumba Navunya. Thank you, Dr. Mushin, for such an excellent presentation. How can we escalate this advocacy to the president, policymakers, funders, and the private sector? So, Patrick Ochen, you can unmute and then give your comment.
Thank you so much, Dr. Mushin, for that nice presentation. I'm called Dr. Patrick Ochen from the UPDF. I have appreciated the presentation. I want to just make a few comments. One is that the presentation it reflects what we are supposed to do, but most of us are not doing what we are supposed to do. And we have to find the reasons why we are not doing what we are supposed to do. Two, I look at the presentation in two perspectives. One is what concerns what we can do by ourselves as health providers. And two, the other bit is those who are concerned with the policies. What we can do by ourselves, we can do it. It is only changing our mindset. I think we have decayed a little bit that we don't look at these mothers or these patients as our customers, whom we are supposed to actually do the best for them. A number of people have become treating like government duties as part-time jobs. A reason why very little time is given to these mothers. And it is worse at the higher level. the higher you go at the hierarchy of medical, the more we see the decay. Somebody goes to work in 5 places. What time do you give to this mother? We think about it. For the presentation, I would pray that this presentation should not only be limited to the health service providers, but should be extended to the policymakers. You brought out that we should have effective means of transportation for referral, but most times you will find that even there is no fuel in the ambulance. For those hospitals and health units that have ambulances, patients are supposed to buy their own fuel. Is it sustainable to this poor woman? It is not. So I pray that this presentation should go beyond the health service providers and take it also to the policymakers. Allocate resources to us so that we can comfortably work and deliver to the best.
Thank you,
Most
Doctor.
hospitals probably have no ambulances. Facilitation for the health workers is actually not there. How can you move 5 kilometers to come and work, rent your own accommodation? I think that it should be tailored towards policymakers as well to allocate funds and resources for us to work diligently towards our patients. Then lastly, I would like to re-echo one thing about documentation. Every mother that turns up is a potential legal issue. If you document poorly, you know you will fail to defend yourself. I urge all the people who are listening to this presentation that the documentation of whatever you have done is paramount, and it should be done from the time the mother reaches you. Otherwise, it will boomerang on you one time. It has happened to several people. And if we can pick a leaf from here, we should start tomorrow doing things differently. Thank you so much for the nice presentation.
Thank you, Dr. Chen. I think as we're coming to the end, maybe some of the comments before Dr. Mushin can answer. One is about positioning of the mothers during second stage. Can the mother take up her own position? Yes. Women should be allowed to take the position of choice during labor, during childbirth. So I think that is fairly answered. Then, of course, example like kneeling, there is in the chat, Dr. Josephine Namialo sends out the link for the the UCU Masters for Public Health Leadership application. So please look at that when you're there. Then, of course, there are some issues here that I think are beyond the scope of this presentation, but touching on advocacy around the issues. So, Dr. Mushin, you can give some remarks about this, then we can start to close this.
I would like to thank everyone who listened in, everyone who asked questions, and everyone who is participating from everywhere. I can see there are quite a number of members of the Save the Mothers alumni group. Even others from Tanzania are logging in. Thank you so much. This program is in Tanzania already. So this program is already in Tanzania, so we thank you so much for logging in. Short-term courses for this kind of program, the Masters of Public Health Leadership. So we have this Masters of Public Health Leadership, which is for 2 years. And like I said, 2 years, you're doing it online. Even exams, you do them online, by the way. But You appear for 2 weeks at the beginning of the course so that we equip you with the skills of how you're going to maneuver through the course. And one of the semesters will bring you on board such that you go and experience what really happens in the health facilities, what really happens to the mothers in the community, because many of us will not be even health workers, so that you can put in context what we talk about. For the short courses, we have short courses designed, for example, financial literacy and self-leadership. And this is a very important short course for all of us, the health workers. We've conducted this in some health facilities. We want the health workers to be happy. We want the health worker to have a farm. In the evening, when you finish your duty as a midwife, at 2, at 3, at 4, what do you do? Do you go back home? Do you watch a movie? Do you be on WhatsApp? Or you can use this time to improve your income so that you can enjoy your practice as a midwife. So short courses exist on leadership, but also on emergency obstetric care. And we've been offering this in the Mother Baby Friendly Hospital initiatives. This year we are rolling out to the Greater Kayunga LNMS. And we hope to roll out even in 2 other LNMSs. Mr. Mulumba Nabunya asked, how can this advocacy be escalated to the president, policymakers, and funders? I want to thank Nabunya Mulumba. And I want to say that, number one, you and me are the first change makers in our communities. Once we understand what needs to be done, for example, in a health facility, anyone can donate a kettle for boiling water. I've been to a health facility where some of the alumni of the Masters of Public Health Leadership, one of them donated a little cylinder, gas cooker, for mothers to boil water and funded its refill for a given period of time. And this created change in this health facility. So we are the change makers. The president is there at the top, the policy makers, and many of us are policy makers actually. Because you find that many of us are the in charges of the ward. So we make policies on that ward. Many of us are the superintendents of the hospitals where we work. Many of us are LC1 chairpersons. Many of us are fathers, the heads of the families. But still, we want to invite funders, and many funders have come on board. For example, in the establishment of HDUs, we've worked with several partners. But it starts with us. Let's be the first funders in our communities. That's what Mother Baby Friendly Hospital Initiative is all about. It's all about equipping ourselves with this knowledge so that we go and change the communities where we live. James Were asked about the birth positions, and I want to thank Dr. Musana for ably and satisfactorily answering that. Patrick Ochen asked, how can this program be extended to policymakers? And like I said, it starts with us, and it's us to take it to the policymakers. If I identify that in my local area, the bed, the operating bed, is as old as 40 years old, and the mattress is torn, it should be me, the first one, to raise it in my community. And so I was at our health facility. The bed in the ward is broken. You know, in these dialogues we are having in our health facilities. And, you know, in this dialogue, if our leaders even hear it from us in these dialogues in the community, we shall start seeing people flooding and bringing these things. Ministry will be able to come on board, and all other stakeholders. So let's own up as a community. This is what Mother Baby Friendly Hospital Initiative is all about, is to ensure that the health worker, the community are working together to make sure the mother doesn't die. Then we make sure that we bring also our policymakers on board, but let's own the change. Let's be the change makers. Anthony Ruhanga Ebare asked, how is this certification of mother baby friendly hospitals done? So what happens is that a team from Save the Mothers comes to a health facility. We do an initial assessment together with the team. And normally this team has also a community member. But as a program, we've made sure that we put an alumni as a mother baby friendly hospital initiative advisor. This person many times is even not medical. So we make sure that it's multidisciplinary in nature. It's not only the health workers. So we do the initial assessment. For example, we find out that the mothers in antenatal are lining up where there is no shade. When it rains on them. This is not science. It doesn't take anyone qualified in medicine to know this, that an antenatal mother should not wait under the sun. Then we say, okay, that's one need identified. We also say, okay, when we went there, we realized that there are no curtains in labor ward. The walls are very dirty, full of blood. Those are basic things. But we also go into serious obstetric emergency management to say, does this suction machine work? Is it broken? What can we do? So we list the things we feel that we found from the assessment, and then we prioritize together with the health facility. After prioritizing, we do what is called mobilization of funds, where funds are needed, where it needs the CMEs. For example, if we identify that management of PPH is still lacking in this facility, we organize sessions to train. Then after that, we make sure that the interventions are done. When the interventions are done, we give ourselves a time, normally on a quarterly basis, to say, when are we reassessing again? When we reassess and we find out that actually we've attained what we set out to achieve, then we certify. Save the Mothers gives you a certificate that says, now you are a mother baby friendly hospital. And then next year we come again after a quarter to assess, are we maintaining? Are there areas where we need to improve? And this engagement involves the local leaders, it involves the health facility, it involves the community, it involves the mothers themselves through the dialogues. Because, for example, the dialogues are one of the key things we assess for. Was the dialogue conducted? What is the community saying about this health facility? Normally, you, the health worker, you will not know that you're rude, that you're shouting at patients, that you're slapping them. To you, it might be okay. The community will tell you. So it's part of assessment. And we normally welcome such kind of feedback positively, but we also give feedback to the community. Tell them, but you are also coming late. We feel if we are to achieve this, we need you to do this. Let the priest go on Sunday and talk about it. So finally we said, did the priest talk about it? In the local council meeting, did we talk about it? So finally we assess the community, we are assessing the health facility, we are saying, have we achieved? And then we certify. So that's how we certify. Thank you so much. Back to you, Dr. Musana.
Yes, thank you, Dr. Nsubuga. We appreciate the talk, and we hope that we can also learn to try and get accreditation for being mother and baby friendly in our hospitals all over the country. There are some members here who are from far. One of them that joined early was Aguti, Opio, Catherine, all the way from Nebi, Coach, Health Center 2, I think Center 2, Center 3. So members, please, I'll hand over to BHF now, and we can then close the meeting. Thank you. Benjamin, over to you.
Thank you so much, Dr. Musana, for moderating this session. And Dr. Nsubuga, this has been timely, and I'm happy that it has come. And to members who are on call, we are continuing with this session is with Save the Mothers. So even next Friday, kindly inform your friend to come. You know, when we were studying health education, that was always the last word that we could talk. Inform your friend to come and attend a session on Friday. Let me hand over to our CEO to give his closing remarks. Thank you. Yeah, thank you so much, Dr. Nsubuga and Dr. Musana for guiding this discussion. As Busoga Health Forum, we are so proud of you, Save the Mothers program. And we are so proud of you, Dr. Musana, and members who attend our CMEs. You've made us who we are because your attendance has made value for our existence. The Busoga Health Forum is a platform, and one of the objectives is to do this kind of engagement, engaging communities, but also empowering our health workers in this region. I am also a trained person from Uganda Christian University. I did the Save the Mothers program and the leadership program. And the Save the Mother, Busoga Health Forum comes as a product because we've based on the knowledge we got from UCU to build a platform. Save the Mothers, you are working within your areas because you made us, and this is a platform that we've created for our people. We only want to encourage you, Save the Mothers, to formalize with us. I think Benjamin will be reaching out to you, Dr. Nsubuga, for how we can formalize this relationship. Because for us, we are in the communities, we can help and make sure that these good lessons reach our in charges of Center 2s, in charges of Center 3s, and those in charges of the maternity units in the different areas where it matters a lot, where the mothers are dying because they are just having a small challenge of governance and decision making that is making them die. So I think Save the Mothers is a challenge that we work out to extend our engagements to the grassroots people who are dying because of simple things. I know as you talk to us, we appreciate that as you save the mothers, you save us, the fathers, you save the children, you save everyone, and all of us want to be saved. So we want to thank you so much for sparing time, and we want to invite you again to engage with us. This is the country's top CME platform, and want to let you know that last 3 months we reached almost 4,000 people with this message. We had 3,372 in 13 sessions. And so we want to continue with research, and Save the Mothers, you're welcome to be attending these sessions. And for that matter, Dr. Nsubuga would like to take this opportunity to thank you on behalf of the Busoga Health Forum for presenting to us this important lecture, this important engagement that you have organized. And we give you these certificates, which is signed by our board chair, Professor Peter. And you take it, pin it in a Save the Mothers, or pin it in your house as a note of appreciation from the Busoga Health Forum. And Dr. Musana, we thank you so much for always being there, working to save the mothers in our country. And God bless you so much. Thank you, everyone. God bless you. Have a good weekend.
Thank you so much for that wonderful certificate. I appreciate, and definitely Save the Mothers is proud to receive this. Thank you so much on behalf of Save the Mothers.